And live from Brussels and Berlin, it's ZN Live. We are very happy today to have a guest on the show with an extensive expertise, Dr. Barbara Rath, who's actually been trained in Harvard and Stanford and many other institutions with over 30 years of experience. She co-founded the Vaccine Safety Initiative in 2008 and has a very interesting perspective on communication, bringing tech, science, and communication all together. So Barbara, great to have you on the show. And I want to start with one burning question, I think, for people who work in this space, which is about the infodemic, the misinformation that we're seeing around vaccination. We've talked a lot about this over the past few years. In your experience, do you think the problem is getting worse, or do you think people are starting to get to grips with the problem and starting to solve it?
I think it's fragmenting in a funny way. Basically, I think there's more and more inequality in access to good vaccine communication and good health communication in general. We find that what used to be common understanding of subjects, a common source of information. I remember the very early days of my childhood when we still had 3 television programs, and that means people divided themselves up among those and watched the evening news there. And of course, I'm a big fan of democracy and diversity and on all these good things. But this creates a very difficult communication environment where one person heard one thing, another person heard another. This goes across families. Sometimes the youngsters are looking at different sources than the grandparents and the parents and the children and so forth. And maybe my neighbor is looking at something entirely different altogether. And that's making it very difficult for, let's say, reliable sources of information and scientific or science-informed sources of information to get to those people who need that information most. So when we first started, as you know, we both are fans of design thinking. When we first started a project on vaccine communication in 2011, in collaboration with the Hasso-Plattner Institute in Potsdam, near Berlin, that was one of the things we talked about. We talked about the fear terminator. Like, how can you, even then we said Google search algorithms are programmed such that if you search for something that isn't real, such as the link between MNR and autism, but very popular among people, then you dig yourself down into a rabbit hole and you find only information that proves that perceived or misperceived link, but you find nothing that will correct that. And it's, and since then, with the advent and the ubiquity of social media, what many people do not realize is there's $1 billion market behind advertising revenue online, for better and worse. Nothing's for free. So the longer I'm afraid, the longer I stay online, and the longer the cash register is ringing for the respective social media platform that I'm on. That's a very simple equation that a lot of people aren't fully aware of. And so there's a vested interest in keeping you online for a long time. Makes sense, right? But psychologically, if somebody gives me some reassuring news and says the weather's great outside and everything's good, there are no natural disasters, no earthquakes, everything's fine, I'm done with this and I move on to another topic. However, if somebody tells me, there's something, some clouds coming up in the background and look where they're going, and this is the weather forecast for tomorrow, and I've been in natural disasters, so I'm not trying to minimize their threat, but sometimes we had situations where things were blown out of proportion, and then people are fatigued in a funny way from all the stress-inducing information they're receiving, also on television. It's not just online, right? And so that then people become numb. Become, as a doctor say, the word immune here. They become fatigued from pandemic news, from scary news, and at some point, a natural tendency kicks in to just say, you know what, this is not part of my everyday life. I just want to completely sign off of this. I don't want to, so either people are completely into it and very, very scared, or they kind of have this other tendency to say, you know what, I'm just going to switch this off, and I had it. And both are dangerous, right? So when we're seeing a real threat, the people who have signed off will not respond, will not take advice or listen to recommendations, and therefore put themselves and their families at risk. On the other hand, it's difficult for a layperson, even for professionals nowadays, sometimes to distinguish a real threat from something that's still marginal at this point, and that we should maybe work on preparing, but that hasn't happened yet. And that's a difficult task for science communication, not just in medicine, but if you're in geology or meteorology or social sciences, in economics, there's so many areas where risk analysis, risk perception, financial risk, economic risk, ecological risk, all these things are floating around our heads. And I personally, know very little about, let's say, the risk of a nuclear power plant. I just hope that the people who are dealing with it know what they're doing. So also the expertise is fragmented, right? Just having a good natural science education doesn't mean you know squat about the risk of specific IT solutions and other things. So you're kind of hoping that the experts know what they're doing. But that's also giving some sense of discomfort, because the more you have a general education, the more you tend to dig into things you read and think you understand them. In medicine itself, the know-how is very fragmented. If I'm a radiologist or a liver transplant surgeon, it doesn't mean anything about my knowledge on vaccination. I may have an MD behind my name, but I still have no idea, because it's not happening very much in my training.
Yeah.
So I think what's making the global communication efforts, such as by WHO or, groups, even ZN, who are communication specialists, it makes it difficult for you to reach the people you want to reach most, because they either signed off, or they think you are on a side that they're not part of, or, whatever their perceptions may be. People are not as open as they think they are. And I include myself in that.
Mm-hmm. Yeah, no, it's you're making very interesting points, especially the business model of a lot of these companies that essentially want you to spend more time and get more engaged, as well as the fact that we're not used to this environment. We're not used to this avalanche of information. So, what I'm hearing is that you think that, issues are getting worse to some degree, or at least in certain spaces. You and I have both been working on projects. We met in India for the IPA conference, which was about discussing how doctors themselves can play a part in this. And I want to come back to, what can we do about this? What are you currently doing? Because you're very engaged with this. You're doing some very interesting technology work in this space. So, the question is, what do you think doctors, parents, and the public can do to be better informed, and what is your initiative doing to change the conversation?
Well, we were launched 2008 in Vienna for a reason, right? So there were very bad events happening at the time. It was a major outbreak of measles, which is a completely vaccine, not just preventable disease, but you can eradicate it if you vaccinate enough. It hasn't happened yet, but it's possible. So it was a huge outbreak. I was working in Vienna at the time in the ICU, and I remember that very vividly. And at the same time, the HPV vaccine introduction, which was our first big, other than hepatitis B, maybe a cancer-preventing vaccine ever, woman empowerment galore. And the introduction landed, as I say, flat on its nose. It completely failed because of miscommunication. And we were sitting around a big coffee table in a Viennese coffee shop, and I was probably getting too much Viennese coffee. Cheers to that. And I thought the input from these people was so interesting, because they came from low and high income countries and middle income countries, from all 5 continents, from many areas of expertise that I am less familiar with, that is not necessarily medical, including IT, including medical anthropology, linguistics, risk analysis, and so forth. And I thought this was such an interesting composition of people that I said, well, you know what, we should start a think tank, a scientific think tank, not a lobby organization, but a scientific industry independent scientific think tank that really tries to dig deep and connect the dots between things that often fail to be connected in the medical everyday or academic everyday life. I used to say that for a long time, academic training tends to branch off into many branches sooner and sooner in your training now. And so you end up at the tip of your branch, you know that one very well, but you may have lost all the little spider webs that you could create in the lower branches to keep ideas together or to create connections between disciplines that need to work together. So that really led to the spark that started VIVI, the Vaccine Safety Initiative. We started as the Vienna Vaccine Safety Initiative, to give credit to that location. And it has since then evolved. I thought we were going to do this for a year or so, and it just kept going. We started writing articles that address some of these gaps between disciplines that aren't seen. Then journals started commissioning articles from us. Then we started design thinking projects, which I'm sure we're going to talk about later. On the concrete level at this point, one of the good examples, I think there's maybe two examples of how this works or how this scientific think tank makes a difference. One good example is we were part of the inaugurating meeting for the Coalition of Vaccination, EU Coalition for Vaccination, that was started by the European Commission as in response to the Council recommendations of 2018. We were all meeting in Brussels. I was sitting next to a colleague from the European Academy of Pediatrics. And the question was, what can we do to improve, to find a more shared voice on vaccination among the different medical specialties that are also fragmented? And we looked at each other and said, the first thing we need to do is improve ourselves, improve our education. Because people are reasonably intelligent. And if I, as a provider, especially as a pediatrician, but that is true for many medical specialties and also nurses and midwives and pharmacists, if I start waffling, as I say, or talking some generic stuff that doesn't answer the question that I'm being asked, I'm communicating something. I'm communicating that I don't know what I'm talking about, and I'm communicating that I'm not wanting to disclose that. And I'm communicating that I don't put enough effort into this area of my training. And there are a lot of people, many studies, including the first one we did in Vienna, visiting kindergartens, asking parents questions. We know that the physician or the healthcare provider is the most trusted source of vaccine information. This has been repeated and rediscovered by many studies since then. However, our position is we should not rest on our laurels. It's a task for us. And what our first study we did in collaboration with the US CDC in Vienna, what it showed is it's not just me being a medical professional and I can lean back and say, okay, I'm trusted, wonderful, great. It's the quality of the relationship between the healthcare provider and the patient or person who's hopefully not even sick yet. If you talk about well-timed visits or preventative medicine, that the quality of that relationship determines trust, not just my title or being by nature of being somebody who trained somewhere, right? So I have to earn that trust every time I speak with somebody. And every time I speak with somebody, there's a WHO mandate. I'm supposed to look for their vaccination record, talk to them about it, address any vaccination gaps. That's my duty. This is not happening, right? So there are many, many examples. We have studied with with pediatric associations in Germany and Russia in the early 2000s already, or mid 2000s, and found that an average pediatrician in those two countries spends about 1 hour of an 8-hour workday on vaccine safety communication. However, the vast majority, more than 80%, had no formal training in that. Okay, so one of the first needs we identified very blatantly is training. So we started SECI, which stands for Strengthening Education and Knowledge on Immunization. It is open to all medical professionals, and it is, we're just launching the next website very soon, the next couple of weeks, so stay tuned. You can see the early one under seki.eu, seki.eu. And you will see that we're also asking parents and families and civic society to tell us which areas their providers should be more knowledgeable about on the topic of vaccines and immunization. We ask stakeholders to support their training content. Journalists can find trained professionals. So we're collaborating also with the European Board of Pediatrics and Medscape and other professional training providers. We amplify training created by WHO, the European Center for Disease Control, and other high quality content. We would like everybody to end up being a real vaccine expert who has done the ADVAC training, right? That's kind of the crown jewel of vaccine expertise. Not everybody will go this far, but this platform very soon will allow you to collect training credit over time and to print out a certificate showing that this is the extra effort you've done to improve your training, and that can be linked to your social media, to your practice website, and so forth. That's one example. Another example is that for more, since the flu pandemic, really, we have worked with the Robert Koch Institute and tested solution at Charité in Berlin at the time, creating a disease severity score for respiratory viral infections. Everybody talks about disease severity, right? But if you look at how scientists perceive disease severity in clinical trials, including during the past pandemic, the vast majority of severity outcomes measure not how the patient is doing, but how the hospital is doing, to be provocative, right? So whether the patient is in the ICU or on oxygen or on a respirator or an ECMO or not hospitalized. These are the main outcomes that were studied during these clinical trials, be it vaccines, antivirals, monoclonals, etc. Well, I like to be provocative on this because I think that's absolutely not satisfactory. Because we all know that during the beginning or the peak or the end of a wave of a virus, for example, you may have different chances of ending up in the ICU. Your age, your risk factors, your circumstances, the attending du jour who happens to be working today, the availability of hospital beds, the distance to other hospitals where I could be referred. All these things play a role. My access to the hospital, whether I show up there in the first place. So there is a huge inequality when it comes to the way we deal with respiratory viral infections. For decades, they were being ignored. It was in a pediatric ER, it would be okay, you're waiting for 5 hours to be seen. You have a 5-minute encounter with a professional. They will say, I usually combine it with this gesture, it's probably viral. There is no evidence, but that's my clinical judgment after 5 minutes. And then you're being sent home. What are we offering to these people? This is still the main thing, getting kids to the hospital, and also with adults. It's one of the main reasons for medical encounters, and we're offering nothing. This is starting to change, right? So one of the questions I should ask is, are you vaccinated? Right? Other things I should ask is ask about somebody's risk factor profile. How's the family doing? What is the subjective impact of illness? Now, if I go back to the clinical trials, which should model what we want to see in routine care down the road, if we're doing insufficiently well there, and we focus on endpoints that are not working, such as duration of illness, if nobody knows when it started, we don't know when it ended, but we measure that somehow. If we focus on what the hospital does with the patient, we're very far away from their subjective experience. Meanwhile, if you ask regulatory agencies such as the FDA or the European Medicines Agency, they will tell you, we want to know how the patient feels, functions, and survives. That's their goal in looking at new medicines and comparing them to existing ones. They have realized long before the medical community how important the subjective experience of illness is to a patient or to a person. So we have a severity endpoint app to help a clinician score the patient, discussed with the FDA, and they came back to us and said, well, can you provide something for the patient or for a parent or provider of elderly relatives? The think tank meets on this topic. I tell them what we heard, and the medical anthropologist and the linguist will tell me, well, that's great. You can do a layperson version of what we have for the professionals. But how do people really perceive illness? How do they experience a flu-like illness or COVID or flu? I said, well, great. You guys are the experts, humanities, social sciences, you tell me, right? they say there's no literature on this. We dug through and there was nothing out there. So we're starting a project called symptomsurvey.org, where we partner with patient organizations, with civic society. We created a chatbot available now in 20 languages to help people tell us how they view different elements of flu-like illness against each other, which ones they want to see prevented, which ones they would like to see treated, how different they view these things in children or adults or elderly people, and how this all ties together. It's not easy, even for people who have just gone through a pandemic. Many have never been asked, let alone been spending time thinking about it. Whether, what's important to me? Headache, diarrhea, I don't know, neurological problems, feeling brain fog. What's important to me? What do I expect a medical professional to help me with? What am I willing to deal with at home? What do I never want to see or experience in my life? And how do these things weigh against each other? So that's kind of, to me, it's a prime example of how a scientific think tank is different from just a single person making assumptions. And it is very humiliating and very, very inspiring at the same time to work with people from different areas of work.
And I guess that's where you're applying design thinking to understand the perspective of the patient and the doctors. We had a couple of comments just saying happy Friday from Justin, very good point from Anthony, and Ivan saying, how do you know which doctors you can trust online? So I just want to come to you very briefly. How are you applying design thinking to this? And then this is a question on VR or on tech that I want to come back to.
Yes.
So how are you applying design
last
thinking?
question first with the how do you find who to trust online? I think this was one of the big challenges during the pandemic. As I said, you can be at a prime institution and have an MD behind your name. It doesn't mean you have ever seen a patient in the last 20 years. If you're in the lab or if you're a pathologist, you can answer many questions, but not all. And my very first research interest was in medical ethics and medical history. And if we go back as far as the Hippocratic Oath, it mandates us to stick to what we know and refer the rest to other people. So that's something I felt was important, to be humble and to understand where we don't know. Secondly, how do I find people I can trust? The long-term goal of SECI is to have certifiable vaccine expertise, where, even as a journalist, if you're looking for people for good interview partners, I know journalists are struggling with this, and tight deadlines and also finding good partners. This is part of the mid to long-term goal of SECI, is to say, okay, I can find people that have done training that is proven and that is shown. There are other areas, if you look for people in some of the organizations or involved in the teams that we recommend as reliable, curated sources of vaccine training, and this includes global training providers who provide CME content, but also universities that have a focus on this. Johns Hopkins, Harvard has one, Stanford has groups, European universities in Amsterdam, for example, and others have a strong focus on vaccine education. Those can be featured, and we feature them through SECI. So if you look at those kinds of groups, this is very helpful, and pediatricians want to know that too. Doctors want to know also who to ask when they are finding a question that they can't answer. And the most important recommendation here is, if you are a provider and you're being asked something you don't know the answer to, just say it. It's much better to say, okay, let me get back to you on this. Maybe there is an answer, maybe there isn't yet, but let me look, rather than saying, yeah, science will tell, or generic things like that. Design thinking has become intricate ever since I was at Stanford. I remember even before the formal School of Design Thinking existed, the D School, I was asked, I was an infectious disease trainee at Stanford, and I was being asked by friends in the product design department to help them test and for free pizza, and a postdoc does everything for free pizza, especially in the Bay Area, which is very expensive. So they invited me to San Francisco General Hospital, which was one of the first hospitals hardest hit by the HIV epidemic at the time. And they were creating new models for these needle drop-off boxes, that have become very prevalent ever since hepatitis B and HIV and other viruses. And many of them are very cumbersome. You have your hand on something else, you're trying to hold a limb. As a pediatrician, usually you're trying to hold something, a needle in place or something, or an infusion, and then you have to drop off this thing in a box. And that's really annoying when it doesn't work, or they haven't been emptied enough, etc. So they had me eat pizza with one hand and try and drop off needles with the other to invent new user-friendly drop-off boxes. And that's just an example of how design thinking emerged. It really came from the thought process of a product designer who puts the user at the core of their efforts, who goes in these loopwise fashion from very early concepts and idea creation, ideation, as we call it, to rapid prototyping, many iterations, but the humility of going back to the initial question, which we call a design challenge, usually starting with how might we, going back to that question throughout the entire development process, and not being satisfied with your first throw, your first attempt, being in close connection with the end user to make sure that what we do serves the person at the end. And this is something I think many industries have discovered. There are many other innovation techniques since then, but I think this was still one of the most groundbreaking ones. And if you look at clinical trials, for example, in industry, I think my experience as on the other side, who's not in industry but running clinical trials at times, you see that there are these specialists who are handing off a study from cell experiments to animal experiments to human studies to phase 1, 2, 3, 4. 4 is kind of beyond licensure or pharmacovigilance. They're specialists for each of these phases, but the global view of, okay, I have a candidate for a drug or vaccine in early development. Will this be feasible in a 3-year-old? Or, will this be digestible? Or will this be doable if it's like 8 doses a day, right? These things need to be applied much sooner in the development process to end up with an end product that is actually user-friendly.
How do you see the irruption of new technologies, like, for example, AI? And, me personally, I'm a lot into virtual reality and all that. We know each other. So, and every time I'm here on Sudden Life, I have the opportunity to bring something around that. How do you see these new technologies helping on several things that you're talking there, like a design thinking, for example, or education, for example, how AI, for example, is bringing ways, you were talking about chatbots that you have developed and all that, how that can help also on the different audiences, or the different potential patients, and also how maybe, for example, virtual reality is helping people also to understand much better the situations or the context of being ill. I don't know how you see these new technologies helping.
Like everything, technology has a promise and has also risks, right? I would almost defer to the risk analysis specialist in our think tank to tell you an exact assessment. That now is becoming a field for risk analysis studies, finally, as have other areas, right? My nature as somebody who likes precision medicine and personalized approaches, I see that this kind of technology holds a huge promise, right? So if I'm going to seek advice online or in person, these tools can help a doctor provide better information, but they can also help you sometimes take the doctor out of the system and get something, first of all, for yourself. If you don't want to go wait for an appointment. That is kind of neat, right? The idea that I'm not getting a generic statistical answer saying, okay, overall the risk is such and such, but maybe potentially an answer that is tailored to my own needs or to my own profile, to my own character, my own preferences, right? So that in principle, I hold very dearly, and I think it's very helpful. We've been working with colleagues at the Department of Computer Science and Bioinformatics at Free University in Berlin for a long time. We still do. We've worked on feature selection. Can I look at a patient's pattern of symptoms and predict which virus they have, or at least select diagnostics more intelligently? Can I understand the wave pattern of respiratory viruses better? Can I do change point and other predictive mechanisms that are usually used in the financial world and apply them to the seasonality of viruses? I can talk a lot of nerd stuff on it. It's fun. There's a lot that can be done. However, of course, talking about, such as virtual reality, the playful person, the pediatrician in me says, hey, that sounds like fun, and I can have much more lively training content than if I'm very abstractly clicking through a multiple choice questions, which is sadly a lot of the life of a medical student nowadays still. Maybe this can be a much more lively learning experience, and it can be closer to reality, quite literally. However, talking about the beginning of our conversations, the fragmentation of what people know and experience, and the ability to distinguish between virtual and actual reality is becoming a blur for some people. We're not quite sure about the safety of these tools in children. We have to work with the other disciplines, medical ethics, history of science, historians, I think, are important here, risk analysis specialists, IT, all these different groups, once again, to see where we can apply these promising technologies to the utmost benefit of the user.
Mm-hmm.
Yeah, so we have some comments which we will continue to discuss online, but I want to go to recommendations. Barbara, what is your recommendation for our viewers and listeners?
As I said, science communication is an art, any kind of communication for that matter. There's a film that first aired before the pandemic, in fact. It's called it's just called Unseen Enemy. It was a documentary film by Janet Tobias in New York. She's also affiliated with Columbia and Mount Sinai. Fantastic science journalists, in my opinion. And she went around the world to discuss with many experts in different relevant fields the risk that we face for pandemics in the 21st century. And while she was working on this, interviewing also parents of children who had severe cases of flu, you can see me ride my bicycle in Berlin and talk about that. They went to, poultry markets in Phnom Penh, talking to colleagues at the Pasteur Institute who were washing the poultry and testing for viruses. While they were doing this work, Ebola happened, Zika happened. It now seems like long ago after COVID, but the relationship we have with nature, the encroachment that we have into the natural habitat of animals that are now coming closer to human living areas or vice versa, all these environmental risks that increase the risk of infectious disease, international travel, all of those things are addressed in this film without being fear-mongering, but really, and quite understandable to just anybody who has an interest in the topic. You can see it as a road movie, you can see it as a science movie, and it was a documentary produced with Arte and CNN in collaboration. I think you can still find it online. If you get yourself a copy and you have a nice evening where you aren't afraid, watch it and learn from it. I learned a lot from working with Janet on this project.
Excellent. Jesus, what is your recommendation for the week?
Well, I always come back to this same topic. So there is an article actually in Vaccines Today already from some time ago, but written by Gary Finnegan, who was here some weeks ago, about virtual reality and vaccination and how actually that can make a difference. And I think it's a nice article with an interview with Glenn Nowak, where he's showing some experiments of how actually the use of virtual reality is helping people to understand in the context of what a disease is and how the vaccine can help for that. For example, I think this is interesting. On the other side, for the people who want to test and all that, I see a lot of potential in ways of showing to people and to educate. There is an application online that is for free that is called Human Anatomy VR. It's a bit far from that, but for people to understand how actually all the body works and all that, very interesting on VR. So even for adolescents or students and all that may be interesting. So,
excellent. So my recommendation is actually kind of a classic. It's called Indistractable by Nir Eyal. It's a book about technology and how you can basically stay focused within all the technology tools that are designed, as you were saying, Barbara, to distract us. And in fact, he started as a tech developer building the apps like Facebook, Instagram, that kind of pull us into that world. But then he was saying there's a lot you can do to stay focused. You need to learn to discipline yourself. And he's got a series of very practical tips. And what I really like is that, and I think we probably share this, that technology can be used for good and for evil. But if you as an individual understand it, you can take action that allows us to make the most of it. So it's not that we're passive victims, but we need to work on making the technology better. So that is all we have time for today. Barbara, it was great to have you on the show. Looking forward to continuing this conversation online, and have a great weekend. See you next time. Bye, everyone.
Bye-bye.
Thank you. Bye to Brussels.